A very good afternoon to you, and welcome to the post-lunch session of glaucoma. I am Richa, and I'll be talking on a very simple way to evaluate the optic nerve head pertaining to glaucoma especially. So evaluation of the ONH is very, very central to the diagnosis of glaucoma. And the aim of any kind of ONH evaluation should include the diagnosis, as in you should be able to diagnose whether the nerve that you're seeing is normal or abnormal, quantify the damage that has happened, and analyze what is the next step. In our practical OPD, we have a very limited time, hardly 10 to 15 seconds, where you actually have to glance at an optic nerve, and you should have some key features on which you actually focus, and then you strategize the further action. So let us look at this optic nerve. Whenever we are looking at an ONH, the first and foremost thing that we should be able to do is we should be able to delineate the scleral ring. Look at the upper margin, look at the lower margin, and here we have the disc diameter, right? And in a similar way, delineate the cup, look at the cup edge, the superior border, the inferior border, and you have the cup diameter. And so now we have got the CD ratio, and the area between the two margins is nothing but the neuroretinal rim. That's the basic of ONH evaluation, right? So let us look at few of the changes that may happen in glaucoma. I've divided the changes into two parts, intra and peripapillary changes. The first one is the optic disc size and shape. Why is it important to actually look at the size of the disc? That's because a small disc will have all the axons compacted together. Any focal damage will lead to higher, loss of the axons. So here we have two pictures here. If I asked you the CD ratio in both the pictures, both of them are roughly 0.55, but then the right one is a normal disc. It's a large disc. The left one has a focal notch inferiorly with a corresponding NFL defect, and that's an abnormal disc, right? And how do we actually calculate it? Look at the graticule mark at your slit lamp and multiply it with the correction factor with respect to the lens that you're using. Now, I've talked about the scleral rim, the importance of that. At one glance, we'll say that it's a very large disc with hardly any cup there. But then again, look carefully, that's nothing but a myopic disc. So the scleral ring is actually very small. In few of the patients, it's not always possible to actually delineate the scleral ring. This is a 13-year-old female with a counting fingers half-meter vision, and this was a unilateral involvement of the disc. So this actually was morning glory syndrome. Similarly, a patient of 45 years with a bad vision, and this was a disc coloboma. There was also an intercalary membrane which was picked up on B-scan. Coming to the neuroretinal rim, so it's nothing but the area which is actually occupied by the retinal nerve fiber axons. So it's important for you to look for two things. First is the pattern of the thickness and any area of focal thinness. This is the isn't rule, which says that inferior rim is more than superior, more than nasal, and then temporal. So we may have focal notching or thinning, which is present in all these three discs, okay? This is a case of a 49-year-old female, a case of open-angle glaucoma. So again, if I ask you, you will tell me that the left eye definitely looks abnormal, the right one looks okay, yeah? But then if you look carefully, even the right one has a NRR slope with a corresponding field defect. Left eye definitely has a gross NRR defect. So this again is an 18-year-old male. If I ask you what is the CD ratio, you might say right eye is okay, 0.1 to 2. This looks cupped. So, but is it really cupped? It's not cupped. It was a case actually of traumatic optic neuropathy. This is actually a pallor, disc pallor, no cupping. So again, what is abnormal if I ask you? The right eye, CDR is around 0.55, left eye is around 0.45. You might say that the right disc is abnormal, but then we sort of limit ourselves with glaucoma. There's nothing wrong with either of the discs. it is this. This is actually a case of CSCR. So don't limit yourself to one thing, you know. Look at the eye as a whole. So we may have overpassing of circumlinear vessel. There may be lamina dot sign, which is nothing but exposure of lamina cribrosa seen here. Coming to the cup configuration and the CD ratio. So again, cup is nothing but excavation in the optic nerve head, and it can be delineated by a sharper edge, a vessel bend. Again, CD ratio, we have already discussed about it. The right eye, if I ask you, it's around 0.15 to 2. Left eye definitely looks around 0.9. Also peep inside the cup. So this was a very interesting case, a case of status post VR surgery, post SOR. So there was a small silicone oil bubble which was seen there. The CDR looked okay, but then eventually, you know, the CDR actually kept increasing. So always peep inside the cup also. Coming to the peripapillary changes, we may have optic disc hemorrhage, so it may precede an optic disc change or a field loss. If it's a new patient, it may precede the changes. If it's an old patient, you may need to reassess the target pressure. So many a times it's very small. You actually have to actively look for the trans hemorrhages. Nerve fiber defects may be localized, may be broad, wedge shaped like this, or may be diffuse like this. Okay, so this was a case of a 30-year-old male. Pressures were 12, vision was absolutely okay, but he has been on steroids on and off since many years. There was a PSC both eyes, and this is how it looked. A very diffuse sort of RNFL defect. This was the OCT scan. 44-year-old male, primary open-angle glaucoma. Again, there was also an hole-in-host plaque here. You can actually visualize the defects very nicely. Diameter of retinal arteriole. So you might find focal arteriolar attenuation in cases of glaucoma. So here it is associated with this nerve fiber defect. And can you really spot the difference? You know, there's actually a gross difference. This has a diffuse arteriolar attenuation. And the last one is peripapillary chorioretinal atrophy. You have the central beta zone and peripheral alpha zone. So in non-glaucomatous eyes, PPA is most commonly seen temporally. If there is a significant optic nerve cupping, you might see a 360-degree PPA also. Again, this was a case of a 45-year-old male with PSC, right eye, and PSCG in the left eye. Just look at the peripapillary atrophy which is seen here. More advanced here, which is maybe associated with the cupping also. So this is what I was talking about, the 360 degrees PPA. 32-year-old female came to the clinics with complaints of scotomas. If you actually look at the disc, these look absolutely normal. But this was what we found on the fields. The patient was actually operated for pituitary adenoma. So again, always correlate everything. You know, the history, the findings, the examination, everything. That's all. Thank